And so I have this pretty much down to a science. So we will talk about a couple of just oddball things first. There are a couple of exam questions that have to do with glaucoma. One of them is a drug called Dimox, and it's for other things beside glaucoma, because a side effect of this drug is it lowers intraocular pressure. But it's also used for things like altitude sickness and other sorts of odd kind of one-off kind of things. But the problem with Dimox is while it does lower intraocular pressure, which is certainly a side effect of glaucoma, high intraocular pressure, it has other things like it causes paresthesias, which are numbness in the hands and the feet, confusion, and sometimes drowsiness. So this particular drug, while it is used with glaucoma, it's often an add-on for very resistant cases of glaucoma. There's another drug that's used specifically for open angle glaucoma, and it's Timoptic or Timolol. And certainly, while it doesn't have as many side effects, systemic side effects, it has more local side effects. As you can imagine, anytime you put anything in your eyes, it may cause temporary blurred vision, burning and itching, but certainly those things will go away. And because it's so good at reducing intraocular pressure, it's continued to be used. Another kind of one-off thing, topic on this exam is a couple of questions related around pain, in specific to operative pain. Let me turn off my phone. In particular to operative pain, there's several types of surgery as far as procedures. You can have a local procedure, which is something like I cut my thumb on a coffee mug, and so what the doctor did was he gave some local anesthetic, which is xylocaine, actually, with epinephrine. What it does is it blocks the motor and sensory nerves, so he could sew me up, without me trying to choke him down. And so then, of course, there's something called an conscious sedation. And conscious sedation is something that you give your patient, or your patient has when they're getting like a colonoscopy, ECT, shock therapy in the psychiatric patient. They'll give them conscious sedation because basically it just kind of blocks the consciousness. And of course, anytime you affect consciousness, you always want to check respiratory rate because of the sedative properties of conscious sedation. And then, of course, there's an epidural or a block, and that's if your patient is having a baby. What they do is they put the anesthesia or the numbing agent in one of the between the epidural spaces in the spine. And then, of course, there's general anesthetics, and of course they intubate you for that, and they basically take the nitrous oxide and they combine it with oxygen, because obviously you need oxygen. And so during general anesthetics, there are 3 phases, of course. You have to put somebody down, and that's called induction. And then you have to keep them down during the surgical procedure, and that's called maintenance. And then, of course, you have to bring them back up, and that's called recovery. So you put them down, which is, of course, the induction. It's called the induction of anesthesia induction. And when your patient's having surgery, the anesthesiologist or the anesthesia nurse anesthetist will ask a bunch of questions like, have they ever had a response or reaction to surgery before or anesthesia before? And that, of course, certainly can be a deal breaker as going forward with any kind of surgical procedure. So now we're going to kind of go into the antihypertensives and the diuretics. So diltiazem is a calcium channel blocker, and anytime something's ER, that means it's extended release, and obviously you don't chew it. One of the things about calcium channel blockers is they shouldn't be taken with grapefruit juice. And certainly, obviously, you monitor someone's blood pressure that's taken anything for an as far as an antihypertensive. So one of the things we talked about when we talked about these drugs is that there are a couple of things that can determine blood pressure or the pressure in your vascular system. One, of course, is your heart rate. Another is the stroke volume, how much blood the heart puts out with one stroke. And then, of course, the peripheral vascular resistance. So if you have if your blood pressure is high, it could be because number one, you have heart disease, and so your heart's having to actually pump harder, or you have vessel disease, and your heart's having to pump harder to get it through the systemic system. So, as far as pressure management, your heart and your system relies on the heart rate, the stroke volume, and peripheral vascular resistance to actually determine the blood pressure. We talked some about ACE inhibitors, and certainly one of the biggest side effects is the ACE inhibitor cough. You'll have this extensively next semester, all of these drugs, and so we'll get deep in the woods with these. And one of the things you watch out for with your patients and ACE inhibitors, we talked about the suffixes on all of these drugs, of course. The beta blockers are the OLOLs, the OLOLs, and the ACE inhibitors are like the prils. And so always watch out for ACE inhibitors for easy bruising. I mentioned this also in class that thiazide diuretics are the go-to as far as the first line for hypertension. And that's because what they do is they lose sodium, potassium in the kidneys. And what that does is it just causes a loss of fluid volume, which lowers your heart rate, which lowers your blood pressure. Let's see, hydrochlorothiazide, that's another diuretic. Certainly, when you use this drug, you have to pay attention to those patients who are allergic to sulfa drugs. Potassium-sparing diuretics, I mentioned this also, that we will go deeper in the woods next semester on these. Spironolactone is one of the drugs that you'll see quite often next semester as well. Anytime anybody's on a potassium-sparing diuretic, that means that you're keeping the potassium in their system. So you always check their potassium levels. Certainly any sort of salt substitute is high in potassium for sure. And something else about diuretics is, like, if you're on Lasix, you always have to avoid foods that are high in potassium. Foods that are high in potassium are like strawberries, bananas, peaches, which I didn't know. I didn't realize peaches were high in potassium until I started teaching this class. So always watch potassium when you're on any sort of diuretic, particularly Lasix. Sodium and potassium electrolytes are something that you always watch for. Lasix also can cause your patient to become hyperglycemic, because what happens is you lose some of the fluid, but the glucose molecules are really big and they're not excreted in the kidneys. So that leaves a higher concentration of the glucose in your serum. When somebody's on a diuretic, we talked about this as well. Always try to weigh them if you want to monitor if it's working or not working. Certainly a 3-pound weight gain in one day is over that is too much. And if your patient begins to gain weight, then you know the diuretic, of course, is not working. Anytime somebody has heart failure, you want to make sure that they're not gaining weight, because that's certainly an extra load on their heart. Diuretics also, you have to pay attention to patients that take thyroid medications, because once again, those thyroid medication just becomes concentrate when they're on a diuretic, and certainly you must check their thyroid levels as well. Beta blockers we talked about somewhat as well. and we'll certainly get way deep in the woods next semester with beta blockers, calcium channel blockers. But they end in OLOL. Metoprolol is one that you'll hear quite frequently. And certainly while it's given to mild to moderate heart failure, if your patient has severe heart failure, it's just going to compromise their heart function even worse. So metoprolol is one of those drugs you really don't want to give in severe heart failure. And certainly that would be a contingent point to call the doctor, call the provider, or whatever. So I've done a couple of topics. Does anybody have any questions on drugs for eyes? Anything for operative pain and types of procedures that you'll see probably in clinical next semester? And then any questions on the antihypertensives or the diuretics? All right, we're almost there. I posted a exam review from the faculty that teaches for the traditional course, did an exam review over the weekend, and I posted it this today for all of you to listen to. So I haven't listened to it yet, so please listen to it. I know that she's actually a dear friend of mine, Professor Carson. She and I have actually taught together in the ABSN program, and she's exceptionally well. Kara, did you listen to it? Oh, is a Kahoot? Yes, it's a Kahoot. Yeah, it's a Kahoot that I posted. Yes. So be sure and listen to it. She's an exceptional instructor, and it's certainly one of my dear friends. How does grapefruit juice affect diltiazem again? It just causes the diltiazem to it can become toxic. It can reach toxic levels. Tomoptic it's for open angle. It's for glaucoma.
I was actually going to ask about the Tomoptic also. The Tomoptic and the Diamox, those are the only two that I saw on our review that were specific to glaucoma. Is that correct?
Yes, I've covered those at the very beginning of this review.
Okay.
But Diamox is actually, it does work for open angle glaucoma or for glaucoma, but it has a lot of side effects. And it actually was developed for other drugs like other sicknesses or other processes like altitude sickness, and a few other various and sundry things. But it has a lot of side effects like paresthesias, which are, Abigail, it's bad. Paresthesias, which are like numbness of the hands and feet, confusion, drowsiness, and certainly, anytime glaucoma is traditionally an aging degenerative disease, and so my ex-father-in-law actually took it, and he fell out. So, he got dizzy and actually wrecked his truck while he was driving. But Tomoptic is it's kinder and gentler to the system. Unfortunately, well, I didn't even look at it. Honestly, the Kahoot I posted was for what the other instructor posted. So I give up. I apologize if it's not worth a flipola. I honestly didn't look at it. But back to Tomoptic. Anytime you stick anything in your eyes, certainly they may burn, itch, and maybe might even have temporary blurred vision as well. So I hope I answered those questions. So now we're going to focus on GI. Peptic ulcer disease is treated with a trifecta of medications, 3, especially when their peptic ulcer disease is caused by H. pylori. One is a meprazole, One is amoxicillin, and then the other is the pink stuff, the bismuth. Usually that is a pretty good triangle of care. Amoxicillin is maybe substituted with something else, but amoxicillin is typically the go-to for H. pylori. I said omeprazole, amoxicillin, and then bismuth or Pepto-Bismol. Let's see, we talked about long-term antacid use and how it can cause rebound reflux. Antacids like sulcrophate should not be taken with other medications 1 hour before and 2 hours after other meds. Certainly sulcrophate doesn't do anything to the acid. It just kind of covers up the ulcers. It's kind of like a pothole cover. And same thing with that. You should take it. You should not eat 1 hour before and 2 hours after until 1 hour before and 2 hours after the sulcrophate, because it'll defeat the purpose. Because when you eat, your stomach secretes digestive enzymes and hydrochloric acid. So if you eat after you have the sulcrophate, it'll cause more erosion of the ulcer. Compazine or prochlorphenazine, compazine, what it does is it blocks the chemoreceptor trigger zone, and basically it's for nausea. It's used a lot in cancer nausea for sure, because it actually blocks the chemoreceptive trigger zones, and certainly it blocks the receptors. You know, you have those medications that block the receptors, and then those medications that reduce the acid. And proton pump inhibitors are those that suppress acid production. So you have those that make the acid go down, and then you have those that trigger the receptor blockers. So compazine or chlorothiazine does block the trigger zones, and then proton pump inhibitors, those are the ones that suppress the acid production. Let's see, sulcrophate, I mentioned that. It doesn't do anything to affect the acid production, but it does cover the ulcers. Certainly that is one good thing to protect from pain. Zantac or ranitidine, you must take that with caution in people that have renal function disease. One of the things you watch out for if anybody has renal disease is, of course, yellow jaundice, extremely concentrate urine as well. We talked about laxatives and stool softeners. One of the stool softeners we talked about were a bulk forming Metamucil or Phycillium. What it does is that adds bulk to the stool, and you must make sure you take with a very full glass of water. On the other hand, you have Imodium, and that's for diarrhea, and what it does is it decreases gastric motility. We talked about a drug, metoclopramide or Reglan. This particular drug you must watch for because it has some side effects called tardive dyskinesia or EPS. And basically what that is kind of head tics, maybe tongue rolling and things like that. Anytime your patient has any GI abnormalities, whether they're constipated or they have diarrhea, always listen for bowel sounds, particularly if they're constipated, especially before you go mashing on their stomach. Let's see. Zofran is one of those drugs that is given for all sorts. It's one of those like catch-all drugs. It's given for motion sickness. It's given for morning sickness. It's given for a lot of things. A friend of mine that had a tough pregnancy just because of nausea, she took it like M&Ms, but it seemed to make the nausea and vomiting go away. And remember, anytime you have excess anything use, excess laxative use can cause an electrolyte imbalance, and certainly excess anti-diarrheal use can cause, um, your gut can become dependent on all these things. So usually it's better to let nature take its course, but definitely if you have diarrhea, it's best to stop it. The old adage of letting it get out of your system is actually 100% not true. So let's see, were there, oh yes, ticks again, that's right, Alice, it was the Reglan, or the metoclopramide. It may cause head ticks. EPS is basically what that is, and we'll get into that next semester as well. All righty, any other GI questions? All righty, we just got to knock out antibiotics. So antibiotics, anti-infectives. Paige, I went over that. Did you jump on late? Okay. Oh, that's okay. We'll go over it at the end. But this it's just a few questions. Just a few questions. So so antibiotics, anti-infectives. Always watch out for what? What do we watch out for antibiotics or anti-infectives? Something that absolutely anaphylaxis and resistance. So anaphylaxis, what are some signs of anaphylaxis? Facial swelling, absolutely. Yeah, certainly can be bad. Absolutely. So how do we know what type of antibiotics we need? Difficulty breathing, absolutely. Shortness of breath. How do we know what type of antibiotics we need? What sort of test do we do? Culture and sensitivity. There you go. There you go. We and certainly sensitivity, it tells you which drug the microbial is sensitive to. Penicillin is one of those drugs that inhibits cell wall biosynthesis, which is why it's really good for some bacterial infections. We remember, what about side effects of tetracycline? We talked about something in specific in teeth. Teeth staining, absolutely, particularly the primary teeth. Always take the full course of medicine. Yep, kiddos for sure. Always take the full course of medicine. Don't stop because you feel better like me. That's the wrong thing to do. What about gentamicin? Gentamicin is, you don't give with what sort of disease? Renal disease. Let's see, sometimes medications need to get a loading dose, and that means, for instance, there are some that the prescriber will write take 2 the first day, and that's just to give it a loading dose. Let's see, the definition, 2-pack, there you go, absolutely, like a Z-pack, absolutely, there you go. What is the definition of a drug allergy? That's absolutely. That's when you have a drug allergy because the drug causes the formation of antibodies to a drug protein. So then the next time you get that drug, it may cause an immune response or a side effect. Absolutely. It gets worse with each dose. Absolutely. Absolutely. Without a doubt. Gentamicin, like I mentioned earlier, is kind of hard on your kidneys, but also, what else does it cause? Macrolides. What else can it cause? superinfection. Yeah, and yeah, absolutely. A lot of those drugs can cause a superinfection. But in specific, it can also cause hearing loss. Gentamicin can cause hearing loss, tinnitus. And certainly anytime someone has hearing loss or tinnitus, ringing in the ears, ototoxicity, absolutely. Always make sure that, you always check safety. Make sure they're stable enough to ambulate with caution. And certainly you said something earlier about the normal flora overload. So if something is a broad spectrum antibiotic versus a narrow, what's a broad spectrum antibiotic versus a narrow spectrum? There you go. Yeah, certainly some types of those. Broad spectrum is like something broad. You take out the bad stuff, but you can take out the good stuff as well. It can certainly affect the normal flora. Right, absolutely. Absolutely. Broad, many things, but it can also cause issues with the normal cells. Absolutely, Paige. Perfect. And then the narrow spectrum is more specific. A lot of specific organisms, and somebody mentioned it earlier, like specific to a gram positive or gram negative. That's when you use a specific spectrum or a narrow spectrum antibiotic. IV bank, let's see. Anything that is resistant to the drug can cause a superinfection because resistance produces a chemical antagonist to the drug. So the drug can become resistant to the antibiotic, and the bacteria or the microbe can become resistant to the antibiotic, and then the microbe just takes off. So it becomes a superinfection. Let's see, prophylaxis. Sometimes you take prophylaxis. Can anybody think of a case where you would take a prophylactic antibiotic? Dental surgery, absolutely. And certainly valve surgery, traveling, absolutely, very good. All of those things are great. So that was the down and dirty part of the antibiotic summary. And we talked about not a lot, so I'm going to mention this again. And thank you for asking whoever mentioned, or I think it was Paige, whoever mentioned earlier about the operative portion. Certainly, there are a few times and a few different types of procedures. You can have something called a local, and it was actually I was getting my master's, and I was I was I had a coffee mug, and I don't know what I was doing with it. I broke it, and I was trying to glue it back together. And what I did was the handle broke, and I cut like a part of my thumb. And so what they do is when you have something that they can just kind of take care of, I actually worked for a doctor, so it was easy. But what he did was he just put a local in, and a local is like epinephrine with xylocaine with epinephrine. And so they just kind of put it around which it does hurt, by the way, but they just kind of put it around the cut. And that what it does is it blocks the motor and sensory nerve sensation. So then he could just go about like sewing me up, and it doesn't hurt at the time. Of course, the next day it's a little painful. But then there's, of course, something called an epidural. An epidural is it's when the anesthetizing agent is given in the spinal column in the epidural spaces. So that's certainly one of the things that makes delivery somewhat palatable. I'll say somewhat. But I had C-sections, so I did have blocks and epidurals for that for sure. And then there's also a general anesthesia or general sedation, and basically it's intubated. What they do is they intubate the patient, and they take nitrous oxide, and they combine it with oxygen, obviously, and then they give paralytics, and things through intravenously. There are 3 phases of general anesthesia. As you can imagine, first of all, you have to induce or put a patient down, and basically you induce um, you induce a coma-like state. So it's called the induction. And then, of course, you have to maintain that patient in that particular state. And so that's called the maintenance phase. And then the third one is recovery. You have to bring them back up. They can't be sedated, obviously, forever. So you have to put them down, keep them down, and then bring them back out. So those are kind of the 3 phases. Oh, I didn't mention this earlier, and I just have this kind of written. So I'm glad we went back over this, because I would have forgotten this part, and I apologize. One thing, and I actually wrote it in the wrong column. It should have been with the diuretics, but Lasix is also, what other drug should you not take with Lasix? We talked about that when we were talking about diuretics. Dig, there you go. Absolutely. That's another one. Dig. What about NSAIDs? Aspirin, Dig, NSAIDs, yes. Dig is another bad player. I mean, Dig is a bad player. It does not play well with others. There are going to be a lot of drugs that we'll talk about next semester. Yeah, Dig is just a bad actor. It's a bad actor. So I mentioned about the Dimox, about it being pretty systemic, about the glaucoma. It just has, it has side effects that sometimes you just have to use it, but the paresthesias and the confusion and the drowsiness certainly make it unpalatable. And certainly Timoptic or Timolol is a much better option. However, it does have, local but very temporary side effects that seem to not be so drastic. All righty. That was excellent. And thank you for listening to me. And thank you for answering all the questions. Dr. Starkovich, do you have anything to add? Uh-oh. I think she might have fallen off the call. Are there any questions at all? Let me see if I can remember. Gentamicin is a macrolide. It causes Alice, Facilium is like Metamucil. What that does is it's a bulk forming stool laxative. What it does is Facilium. When I think of Facilium, I always think of like the skin on like rice. It's kind of like on popcorn. Have you ever eaten popcorn? You get those little kernel or those little coverings in your teeth. That's kind of what Facilium is like, but it's more fine. And what it does is it absorbs water from your gut into the stool, and it has a bulk forming laxative property. And certainly one of the things that you have to assess is bowel sounds. Assess bowel sounds. Sometimes you may need to palpate, but if somebody's in excruciating pain, certainly you don't be mashing on their stomach a lot, or on their abdomen a lot.
If you take Metamucil and put it in a glass and leave it overnight, it soaks up all the water, and it's like a gelatin in the morning.
No way.
Science experiment. Yeah.
Oh, wow. You could make Metamucil cubes. Yuck. Yeah, you better drink that fast while it's still swirling in the glass.
Right.
Dang. Note to self. Don't leave it by the sink at night. Yeah, it's pretty nasty. Pretty nasty. So let's see, I'm going to run over a few things on the antibiotics again. We talked about anti-infectives that can cause anaphylaxis, which is facial swelling, etc. We talked about culture and sensitivity as the golden ticket to determine what is the best antibiotic to use, antimicrobial to use. Certainly broad spectrum are broad in the sense that it is kind of a catch-all, but it sometimes can cause more harm than good. Certainly it can cause C. diff, and that's certainly bad. Once you smell C. diff, I think that's another question too. Once you smell C. diff, you'll never forget it. Penicillin is one of those drugs that inhibit cell wall synthesis. We talked about tetracycline and primary tooth damage. Always take the full course of medications. We talked about gentamicin, and it's a macrolide. It can cause hearing loss, and it's also used either not at all or with caution and renal disease. That the cephalosporin, there's the C. diff. Sometimes cephalosporin use can cause a superinfection, and the superinfection may cause C. diff. And anytime you have C. diff, your patient has C. diff, you must use soap and water because alcohol, hand sanitizers don't work to kill C. diff. Sometimes you must take a loading dose. Allergy testing, certainly we didn't talk about that. How does somebody get allergy testing? They go to the dermatologist and they do what? Or they can go to an allergist for sure. But they they do those little skin testing things. Yep, skin test page, really good. Absolutely, Kara. The definition of a drug allergy, they're from your system develops antibodies to a drug protein, and then that causes the immediate recognition of that drug protein or that antibody, and certainly the next time you take the drug, you can have a anaphylactic response for sure. We talked about IV vancomycin. Well, we didn't talk about IV vancomycin, but there's a question that talks about IV vancomycin and how sometimes you can get resistant to drugs just simply because they don't work anymore. And certainly IV vancomycin is one of those drugs you can be resistant to, but your system produces a chemical antagonist against the drug, and then of course it becomes ineffective and you can get a superinfection. All righty, well, I've repeated myself. Does anybody have any questions? Let's see, we talked about peptic ulcer disease, and it's one of the causes, H. pylori is one of the causes of peptic ulcer disease. We talked about taking omeprazole, amoxicillin, and then of course the pink stuff, amoxicillin, because it's a microbial. H. pylori is a microbial, so you have to kill the microbial first, for sure. And then you also with the omeprazole, you decrease the stomach acid, and then with the pink stuff, the bismuth, you protect the lining of the stomach. 3 factors, yes, heart rate, stroke volume, and peripheral vascular resistance. I can't even talk. Peripheral vascular resistance. Oh, you're welcome. We talked about a couple of different types of antacid antacids. We talked about compazine or prochlorphenazine. Basically, it blocks the chemoreceptive trigger zones, and then as opposed to something like a PPI that suppresses acid reduction. All of these are, of course, for nausea. You have H2 antagonist, of course. They also they block acid release for peptic ulcer disease. We talked about sulcrophate. It's kind of the pothole cover for gastric ulcers. It certainly doesn't affect acid production, but it just kind of covers the hole so your stomach can heal. Certainly, you don't eat or take anything else 1 hour before and 2 hours after. Same thing with antacids. Zantac, you have to be careful for because it can cause renal disease, and certainly dark urine would be one of the symptoms of that. Again, the bulk forming laxatives, Phycillium, Metamucil, always take with a lot of water. And then, of course, something like Imodium decreases motility. Reglan or metoclopramide has the side effects of the ticks and the EPS. And anytime you have anything going on in the gut, you always assess by listening to bowel sounds. Certainly not a bunch of mashing around, particularly if not a lot of palpation or deep palpation, particularly if your patient has profound pain. Zofran is one of those great drugs for motion sickness, morning sickness, exam sickness. Just kidding. And an excessive use of laxatives and or antidiarrheals are always a very bad thing. Alrighty. How was that, Gang and Pep Squad? So, how would you treat H. pylori? Can somebody answer that? It's kind of a trifecta. Remember, it's the three things. Certainly, you have an antibiotic. Most of the time, it's amoxicillin. What else? Right? Omeprazole, PPI, and bismuth. Correct. Absolutely. You guys got that down. Awesome. Awesome sauce. So let's see. Metoprolol is a beta blocker. Diltiazem is a calcium channel blocker. You don't drink orange juice in a calcium channel blocker, a diltiazem. ACE inhibitor, you might have a cough and you might bruise easy. Thiazide diuretics are your first line for hypertension, or for essential hypertension. We talked about essential and primary or secondary. Essential hypertension is primary, and that's because of no reason. You just all of a sudden develop hypertension. Secondary is for a reason, like diabetes, any other disease process, because it's secondary to something else. Hydrochlorothiazide is used in caution with people sensitive to sulfa drugs. Potassium-sparing diuretics, which you will hear that until you are nauseous next semester. That's spironolactone. That's a potassium-sparing diuretic. Always check potassium. Lasix, you should stay away from foods high in potassium, strawberries, bananas, peaches, and for blood sugar if you're on Lasix or your patients, because it can cause hyperglycemia. Always weigh your patient is on diuretics, weigh them at the same time every day, probably roughly the same clothing, and you don't want to gain 3 pounds or lose 3 pounds more than that in a day. Diuretics also can give you the blues if your patient's on thyroid hormones, so check thyroid as well, function. And certainly beta blockers, the OLOL fellows, while they're great for mild and perhaps moderate heart failure, they're not intended to use in severe heart failure. All righty. That's the end of that story. Any questions? Well, I appreciate you guys' time. Y'all will be very glad that y'all came to test review, I promise. I know y'all have been studying hard, and I'm so very proud of all of you. And so, who wants to say a prayer? And remember, whoever says a prayer, pray for the Astros. They're in the World Series.
If no one else wants to volunteer, I have two girls that would like to say a good night prayer. Okay, hold on, let me turn on my microphone. Okay, can you hear us?
Yes.
Okay, all right, Piper. Okay, you want to lead it? Okay, go ahead.
The Lord is my shepherd, and I am his sheep. He watches over us while we sleep. Watch over us, Lord, by night and by day. Watch over us, Lord, while dance and play. Amen.
Amen. Wow. That was awesome. Thank you so much. I will probably never get a better night's sleep than tonight.